All right, so now to introduce our panelists. I'm very excited to welcome Jeanne Flavin, who is a professor of sociology here at Fordham University, working on issues related to gender, crime, and reproductive justice. Dr. Flavin is the author of the award-winning book, Our Bodies, Our Crimes, The Policing of Women's Reproduction in America by NYU Press, and more than 24 other scholarly publications. She serves on the board of directors of National Advocates for Pregnant Women, a reproductive justice organization which defends the rights of pregnant and parenting women. She was the recipient of a 2009 Fulbright Research Award and received the 2013 Sociologist for Women in Society Feminism Activism Award. She earned her BA from the University of Kansas and her MA and PhD from American University. I am also very pleased to welcome Shameka Poetry Thomas, who is a Global Health Fellow at Harvard University and the University of Ghana. Dr. Thomas is a medical sociologist, race scholar, and reproductive health scientist, whose work focuses on the social determinants of adverse pregnancy and birthing outcomes as it relates to provider-patient interactions during the prenatal trimesters, labor and delivery, and postpartum health. Her target samples are specific to the reproductive health experiences of Black women with genetic disorders in the United States. She was an NIH intramural postdoctoral fellow from 2020 to 2022 and earned her BA from Spelman College, an MA from Georgia State University, and a PhD from the University of Miami. So with no further ado, I will hand it over to our panelists, and Jeanne, you can kick us off.
Okay, now for the big question. Can you hear me? Okay, we've had some technical difficulties, so this will be more multitasking than I'm used to, but I want to begin just by saying thank you to Dr. Fisher and Dr. Schwartz, and of course to Dr. Thomas for, it's really an honor to be here tonight. And I also wanted to thank and acknowledge everybody who's taking time out of your lives to be here. So I'm going to just jump right in. I hesitated about this next part. I do want to just acknowledge though, particularly this week of all weeks, that I'm currently located across the street from Inwood Hill Park, which was once the home of the indigenous Lenape people. And I'm normally not in the habit of land acknowledgements, but I think that this month is a good time as any to begin. So I'm just going to plunge on in. Okay. So as part of a larger campaign to recriminalize abortion, since the 1980s, child endangerment, feticide, and other laws have been and continue to be used as the basis for arresting new mothers and pregnant people, including women who have no intention of ending a pregnancy. To date, researchers at NEPW, which is as of today renamed Pregnancy Justice. I also want to note that I have been a longstanding board member, but I am no longer serving the work of Pregnancy Justice in that capacity. But to date, researchers at Pregnancy Justice have documented more than 1,600 women in the United States who've been arrested or otherwise deprived of their liberty during the period 1973, when Roe v. Wade was decided, legalizing abortion, and 2020. And they were arrested because of their actions or inactions while pregnant or birthing. Now, the early research I undertook with Lynn Paltrow established, and as continues to be true today, is that in a disturbing number of these cases, the initial disclosure of information that led to the arrest, forced intervention, or other punitive state action involved healthcare providers. And since then, that particular finding has been the focus of my research and efforts. In keeping with the theme of social justice in sexual and reproductive health this evening, I'm going to briefly share some of what I've learned. I'm going to mention some of the ideas that have shaped my thinking. I'm going to provide a little bit of background or history into the problem. I'm going to describe some of the complicated context that surrounds these arrests. And then I aim to reserve some time to discuss some possible actions, or maybe that will come forth out of the conclusions. In case we run out of time or Wi-Fi or audio totally abandons me, I am front-loading some of the information that I think is most important. So with that in mind, the first thing, of course, is just to call your attention to the reality of these arrests and the role of healthcare providers in them. The second thing I want to call attention to is, I want to emphasize, is that there is strong consensus among public and medical organizations. They are united in their opposition to doctors participating in the arrests on the grounds that such actions undermine maternal, fetal, and child health. This is, I don't know if it's rare consensus, but it is strong consensus in at least their expressed opposition to the use or threat of punishment to motivate people toward a specific action or decision. The other point I'd like to make is that the criminalization of pregnancy is a rich site for abolitionist critique. Located as it is at the intersection of multiple and related movement priorities, including struggles for racial justice, promoting maternal and infant health, and providing humane and evidence-based responses to mental illness and problem alcohol and drug use. If people are interested, I can also talk a little bit about my own path as someone who remembers not being concerned about these arrests of pregnant people when I first heard of them as a graduate student, to becoming very concerned. In this regard, my thinking has been usefully shaped by exposure to and engagement with the principles of reproductive justice, harm reduction, and more recently, abolition. In the interest of time, though, tonight I will just simply note these and invite you all into conversation later if that's something that interests you. I do, however, want to spend just a moment on emphasizing that abolitionist practice, I'm conceiving it very broadly, and kind of a lot of my work is motivated by a commitment to recognize that our efforts to prevent and respond to harm must avoid even the most subtle or indirect reliance on punishment. And I'm going to pause and move on, but we can always come back to that point, because I am very concerned that punishment is creeping into many of our social institutions, and I've got a lot of concern about that. I also want to spend a little time highlighting some of the fundamental tenets of the framework of reproductive justice, which I imagine that many of you are already familiar with, but I did want to just highlight two features of it. And first, as many of us now know, reproductive justice refers not only to the single right to an abortion or to contraception, but the right to make decisions for oneself, including if, when, and how to have a child. But the other part I want to highlight is that it also includes the responsibility of government and society, that means us, to ensure that conditions support those decisions. So it doesn't make sense to say, hey, you have a right to something if you cannot if your access to that right is either not respected or it isn't backed up by things like quality health care, clean, safe water coming out of your tap, nutritious food. Also, with the limited time I have, I did want to devote some time to providing some, admittedly, and oversimplified historical context that can help us understand how we got to a situation where hospital workers, that we're arresting pregnant people in the first place, but also where hospital workers are reporting their pregnant patients to the police. I mean, how is it that pregnancy came to be criminalized, and how did healthcare workers and other helping professionals wind up participating in this process? So the war on drugs of the 1980s and 90s was widely recognized as racist, and it's now widely recognized as racist and a failure. It targeted poor Black and Latinx people who were living in urban areas, and it led to the arrest and incarceration of literally millions of people in the United States. It also featured national panic steeped in stereotypes rather than science over crack mothers giving birth to so-called crack babies. The panic was informed in no small part by media attention surrounding a small and poorly designed study of 23 infants and the lead author, who was a medical doctor, his overstatement of his findings. As we now know, the mass hysteria was unjustified. The treatment and depiction and characterization of mothers and their children was unfounded, and indeed was the source and cause of much harm. In fact, earlier this year, the Annals of Medicine published an article that identified the impacts of the war on drugs as a social determinant of health in the United States, and not in a good way. It has since been established that crack cocaine and other criminalized substances, including cannabis, methamphetamines, and opioids, simply don't cause the kind of inevitable and irreversible damage to developing babies that these media accounts suggested they did. Drug use is but one of many factors which may affect outcomes. Poverty, environment, and their correlates, as well as conditions in the societal womb, including the consequences of the weathering effects of multi-generational racism and stress. These shape pregnancy outcomes and child development as much as, and quite likely more, than perinatal exposure to drugs. But the damage of that mass panic of the 80s and 90s has been done, or rather, you could say the mission was accomplished. Because the vitriol that was directed at society's most vulnerable women, those who were poor, Black, and used a criminalized substance, was weaponized by abortion opponents in their efforts to strip all pregnant people of their rights and personhood, all pregnant women and people with the capacity to reproduce of their rights and personhood. I also should have stated this early. I do use the term pregnant women and pregnant people interchangeably. That is in part because in all of the court records and media accounts that I've seen, people are identified as women, but admittedly, it is quite possible that they're being identified with a label woman that they themselves would not choose for themselves. And I also want to recognize that there's a harm that's attached to our adherence to the gender binary to begin with. But kind of my compromise point for the moment to recognize that they are being treated, at least in the court records, as women is to use the terms interchangeably. But to recap, the racial animosity that was leveled or directed, or targeted at poor Black women was used to place women who are poor and pregnant in the crosshairs, not only of the war on drugs, but the war on abortion. And as of the documentation of the cases that Lynn Paltrow and I published back in 2013, and in the current documentation effort that is currently underway confirms, child endangerment and other laws could be, have been, and still are being used as the basis for punishing all pregnant people, including those who intended to have their baby. Now, numerous crimes, how does this happen? Just briefly, numerous crimes such as child endangerment, they only require that a creative prosecutor show a risk of harm. Because pregnancy occurs inside a person's body, everything a person does, everything a woman does or does not do could potentially have an impact on her future child and thus provide a basis for arrest. So between 1973 and 2020, with new cases being reported nearly every day, we have seen again, over 1,600 people across the United States have been taken into government custody and or charged with a crime for acts such as experiencing a miscarriage or stillbirth, delaying cesarean surgery, having home births, attempting suicide, having testing positive for a use of a controlled substance, testing positive for using a controlled substance, including ones that have been prescribed to them, attempting abortion outside a medical setting, and for being pregnant and engaging in a wide range of actions and inactions that wouldn't be considered a crime if the person wasn't pregnant. I also want to note that in the majority of these cases, including the many cases where there's an allegation of substance use, the women went to term and gave birth to a baby with no reported adverse health consequences. And the other thing I've mentioned that I just kind of want to recap is that a disturbing percentage of these reports to punitive authorities originated with healthcare workers or hospital social workers. So I would also like to note that in addition to that, our earlier study found that that pattern was particularly pronounced when healthcare workers were reporting Black patients. Now, these disclosures take a variety of forms. And again, in the interest of time, I'm not going to go into a lot of detail on them. But I'm just going to quickly kind of give you a sense of how these come about. Healthcare workers and hospital social workers in all 50 states are considered mandated reporters of child neglect and abuse, and they are required to report suspicions of child abuse or neglect to relevant authorities. However, a lot of times these suspicions may be misguided, unfounded, or rooted in racial or class prejudice. Moreover, healthcare providers, some, I should say, by no means all, or even most, have used, and we assert abused their discretion to report newborn babies and new mothers to authorities based solely on prenatal exposure to controlled substances, rather than considering neglect or abuse allegations that are based on their actual behavior toward the child. Moreover, some states' laws explicitly require healthcare workers to make a report to child welfare authorities based solely on a positive drug test of a newborn baby or the mother herself. In many states, this reporting takes place even though state law does not explicitly mandate such reporting. So healthcare workers throughout the country may make reports to authorities that stem from a misunderstanding of what their state law or their hospital policy, for that matter, actually requires. I would also say that disclosures are just one form of complicity in these arrests. And again, whether it's intentional or unknowing, the impact is often the same, that a report to child welfare is functionally the equivalent of a report directly to the police. Also, one of the things I noticed that's disturbing in the records that I'm reviewing is that often it appears that police or prosecutors request that doctors or social service workers turn over confidential information, and they comply, despite the lack of a search warrant, subpoena, or a court order. Women who've sought help at hospitals after miscarriage, stillbirth, or an attempt to have an abortion have found themselves subjected to bedside interrogations and arrests because a hospital staff person, typically without a legal obligation to do so, reported them to the authorities. Actually, I should be scrolling just to give you an idea, another way of just give you an idea also of some of the media coverage that has accompanied these. In 2000, I would also note that hospital medical staff also have on occasion specifically and formally collaborated with law enforcement to develop a coordinated system of searching for evidence of drug use and then reporting women who test positive to the police and helping the police carry out the arrests. Now, in 2001, in the Ferguson v. City of Charleston Supreme Court ruling, the Supreme Court held that such collaboration, that is taking tests without consent when they could lead to a criminal charge, violated a patient's Fourth Amendment protections against unreasonable search and seizure. But this ruling doesn't apply to civil child welfare proceedings. And again, this is just one of the kinds of problematic actions that we see. Another area I just kind of want to flag for folks is, and many people are now taking up this issue, the issue of healthcare workers failing to ensure or secure specific and meaningful informed consent to drug testing. So, you know, people are being tested, but often without an understanding of what the implications of what that positive test could mean for them, for their child, and for their ability to remain together. Okay. So I don't know that we'll have time, but maybe this is something that we can take up in discussion afterwards. But I do want to kind of get people to think about what are some of the consequences of this practice of healthcare workers being implicated in these arrests. And so in the interest of time, I'll just briefly, share the screen here, and you can see there's quite a number of, this is by no means a comprehensive list. One thing I do want to emphasize, though, is a lot of times people's like, well, hey, if the charge was dropped or the conviction was overturned, okay, she was just arrested. I don't think we should underestimate the harm and the violence that is represented in the arrest and the physical deprivation of liberty. Similarly, I don't think we should underestimate the harm that is often associated with a child welfare investigation, even if it is ultimately concluded that it is an unfounded one. I'd like to talk, so another consequence I want to highlight is noted by medical ethicists who note that one of the main problems with this, and I think why there is such strong consensus among a lot of medical and public health and social work organizations, is that the more physicians and nurses become entangled in law enforcement, the more they resemble agents of the police. And that in turn undermines the trust that patients place in them, which, as I understand it, is at the core of healthcare. That if you can't have, if patients can't trust, and for good reason cannot trust, that the information they provide will be treated with sensitivity and compassion, then they will avoid their healthcare provider or will not disclose information that would be useful or be forthcoming with it in ways that might adversely affect their health. Also, of course, it means that patients will understandably avoid healthcare. It isn't that for someone, especially who's in the throes of a drug addiction, it may not be possible for them to stop using in the relatively short span of a pregnancy. So instead, they may avoid prenatal care or attempt to birth at home and that sort of thing. And then, of course, as a consequence, as Lynn Paltrow and many others are making clear, what's at stake, one of the consequences is the personhood of all people who have the capacity to reproduce. Because this doesn't affect just people who are seeking an abortion or even people who are pregnant. Because in order to establish whether or not somebody's action was problematic or not, you first have to establish whether or not they're pregnant. So this really has ramifications far beyond just the single right to an abortion, but really for the personhood, the full equal constitutional status of all people with the capacity to reproduce. So in my last few minutes, and I'll try to race by these because I want to make sure that we have ample time to hear from Dr. Thomas. So in terms of actions that we can take, again, I want to remind you that there is ethical support for objecting to these arrests. So one of the first things I'd like to say, we really need to know and honor our ethical duties. And part of that means insisting that our policies and practice are grounded in science and respect for patients' human rights and dignity. I'm going to put my glasses on here. Just one thing I want to note is, just as people overestimate the harms and risks that are associated with perinatal drug exposure, people also underestimate the harms associated with reporting patients to the child welfare or family regulation system. And again, as mentioned, involuntary family separation causes significant trauma to children and their parents, and evidence is largely lacking that child welfare involvement makes children and families safer. Again, to the point of making sure we know and honor our ethical duties in whatever capacity that we live and work. And then I also would ask that we might consider organized resistance and civil disobedience where appropriate. And again, here, there is some support from these major medical associations. The AMA recognizes that when physicians believe a law or presumably a practice or policy violates ethical values or is unjust, they should work to change the law. And in general, overall, ethical responsibility should supersede legal duties. On a less lofty, but I think still really important note, I also just want to conclude with remarks of Deborah Small, a lawyer and an abolitionist. A lot of this is work that we can begin doing just in our own daily life, to ask ourselves on a regular basis, to recognize that we are reflected back in the things that we see are wrong in the world. So we can ask ourselves, where am I unjust? Where am I unfair? Where am I oppressive? And as small notes, it's up to us to provide something different, and that something different is rooted in love. So with that, I will turn it over to my colleagues and look forward to the rest of this conversation. Thank you.
All right, thank you so very much. So there's the link that you wanted. Should I put that in the chat? Oh, yeah, I can go ahead and do that. I'll put that in the chat for everyone to see. And I just wanted to give a reminder to everyone that if you have any questions, please do submit those via chat, and we encourage you to do that at any point now. And now with that, I will pass it off to Dr. Thomas.
All right, wonderful. Thank you so much, Dr. Flavin. That was amazing. And also thank you, Dr. Swartz and Dr. Fisher, for this wonderful opportunity to present and give a talk today. So I'll go ahead and share my screen. All right, can everyone see? Okay.
Yes.
Wonderful. Okay, so today we're going to have a conversation, also echoing a lot of the sentiments of my colleague here, framing reproductive health equity. And my research largely focuses on patient perceptions of non-invasive prenatal testing for sickle cell disease among Black women in the United States. And most recently extended to Ghana, Accra, Ghana, which is where I'm currently speaking from. It's about 11 p.m. here. So I'm sending you all some good cheer from West Africa. I'd like to report a few disclaimers. Well, I have no disclosures to report. However, photos in this presentation may or may not trigger emotional responses. And I'd like to kindly ask that no photos of the slides be taken, as this research is currently being developed for manuscript and publication with one of the journals for ethics, bioethics. All right, before I begin, I show a very graphic images throughout my presentations, one to center the story and the historical framework of Black women in the United States. And I show this picture here of Mary Turner. I like to ground my research presentations by dedicating my talks to some of my ancestors. So this is a hashtag movement called Speak Her Name. And so I'd like to speak the name of Mary Turner, who was the first reported pregnant Black woman who was lynched while 8 months pregnant. And this took place in 1918. And I like to show that these images are historical memories embedded in the fabric of the United States. And they still to this day frame and shape how Black women experience clinical encounters, and they shape clinical experiences. So in terms of the story, the history and the story of her story in the United States and the deep historical roots of reproductive health disparities as it relates to genetic technology, I'm sure you've heard of J. Marion Sims. He's often referred to as the so-called father of gynecology. And as you see here, there's a Black woman centered, but she's not centered because she's seen as human. She's centered because she's dehumanized and seen as subhuman. And oftentimes, Black women's bodies were used to develop and further genetic technologies, and cesarean sections, as well as birthing practices and procedures, were largely practiced on Black women's bodies because they were property and commodified, but also because they are under the racist ideology that Black women did not feel pain because they were not human enough to feel pain. And so this shaped the movement of eugenics, as well as deep-seated racial discrimination practices. Another say her name I'd like to point out here is Henrietta Lacks. And so if you know about the polio vaccine, or if you know anyone with sickle cell disease, then you should potentially know about the contribution of Henrietta Lacks. And so in my talk about ethics, it's not just important and critical to highlight centering Black women in empirical studies, but also to center Black women and minoritized women and their contributions to the advancement of science. And Henrietta Lacks and her contributions were largely geared toward polio vaccines, cloning, gene mapping, in vitro fertilization, as well as sickle cell disease, which is the disease of my concentration and research here. And so as I present an overview of the research background in this conversation, I like to point out a few stats. So you probably hear some of the stats that Black women are 3 to 4 times more likely to die from prenatal complications in the US, and they are susceptible to high-risk prenatal diagnosis due to intersecting social factors such as racism and sexism. And I like to point out that regardless of a Black woman is in the high SES or low SES category, she still experiences or can attribute some forms of racial discrimination throughout her treatment processes or her clinical experiences. For example, Serena Williams, she was she's a woman of high SES and access to probably the world's best obstetrician and gynecologist, but she still attributes her birthing experience to racial discrimination. But what does this mean when it intersects with sickle cell disease, in which women with sickle cell are 6 to 10 times more likely to die from prenatal difficulties in high-income countries such as the United States? Even when there's more access to sickle cell treatment, they're still likely to experience complications and difficulties that lead to death, and higher prevalence of comorbidities that exacerbate high-risk prenatal diagnoses and sickle cell crises. And here's where the technology comes in. Non-invasive prenatal testing, or NIPT, is an emerging reproductive health technology. It was first US marketed in 2011, and it has since transformed the landscape of how we see reproductive genetic technology in the US. But it's also being projected to be developed for sickle cell disease at a 2-year projection. So we're literally at the forefront of genomics and genetics. And this is where I like to pick up my passions to kind of synergize these often siloed topics. And so here I kind of give you a layout of what this looks like in my mind and in my heart when it comes to intersecting this research, understanding Black women's perceptions of genetic technology. So I'm spearheading one of the very first of its kind, one of the very first projects in the US that solely focuses on Black women's experiences in genetics and genetic technology and sickle cell disease intersected with prenatal care in this country. I've since completed my data collection at NIH, and I'm currently in the process of analyses, and I'll talk a little bit more about my preliminary findings. My research questions stem from: what are the patient perceptions of non-invasive prenatal testing for sickle cell disease among Black women with and without sickle cell disease? And actually, here's a picture of me and my daughter when she was 6 years old. So just a little bit about sickle cell disease. It is a group of inherited blood disorders that affect hemoglobin. It's the most monogenic disorder throughout. And it's highly concentrated among Black populations worldwide. It's also autosomal recessive. And so that means that if one parent has a trait, such as the father, and the mother has a trait, they can develop a child who has sickle cell anemia from both of those genotypes. And there are different types of genotypes. Here, the most prevalent you see, well, at least in my research, is SS, so hemoglobin SS, but you also have hemoglobin SC, or you probably heard of sickle cell beta thalassemia, and so forth. There have been some major advances in sickle cell therapies that are FDA approved. One at the top that I like to draw your attention to is the drug hydroxyurea. So if you just repeat hydroxyurea, just keep that in mind. But this was developed not that long ago. If you think about it, 1998, I mean, we probably were all kind of here. I mean, at least I was in the 90s, but this is very This is a very new drug. And so when we think about sickle cell and persons living with sickle cell, particularly of marginalized and minoritized groups who have sickle cell disease and sickle cell anemia, and sickle cell trait, or dealing with family members of the sort, they're just now starting to see advances in clinical treatment. And when it comes to hydroxyurea, remember when I told you or asked you to say her name of Henrietta Lacks, and how the HeLa cell line has made major contributions for sickle cell treatment. So sickle cell anemia and also research advancements with the HeLa cells would not have been possible without contributions from Black women like Henrietta Lacks and her cell line. So with my research here, this is the data that we collected in the US. So my team at NIH and the lab that I served in for 2 years, so the past 2 years. This is a flyer that we largely disseminated across country, very widely and very broadly. We drawed on methods using a narrative medicine framework that allows the patient to have their own standpoint epistemology, standpoint theory, or standpoint lived experience, where it sees the patient's data, the patient's story, as legitimate scientific data. And what separates my research from other studies, empirical studies, is that I solely focus on a single population study of Black women to disentangle a group of women in the country that are often seen as monolithic or homogenized. So oftentimes in empirical and quantitative studies, Black women are lumped in as a variable or as a case or seen as an experiment. But in my research, I tend to disentangle that by allowing Black women to have their own lived experiences and shared identities, but also to be different among each other without a standard referent group compared to white women. So my data collection, I was roughly in the field for about 8 months virtually, and I collected data on 40 Black women, 20 with sickle cell and 20 without. So here are just a few demographics. We took a wide variety of demographics, but I just pointed out a few here for time purposes. We also take information on maternal status, and we wanted to leave this wide open. So we did include information on mothers who experience things like pregnancy loss or infertility, or just didn't want children at all. We also took a self-reported race, but also self-reported ethnicity, as well as sexual orientation, and we use insurance status for a proxy for SES. So just a little bit about the results as it relates to the talk today on ethics, and I'll talk a little bit more about what this means in terms of the framework. But as you can see here, we have 2 Black women, both have sickle cell disease, both are mothers, both prefer not to have a child with sickle cell and are pro-choice, right? But we have a divergence here that even though they have a shared narrative, sickle cell disease and their other shared narratives of lived experiences, one is in favor of the genetic technology and one is opposed to the genetic technology. So here we have a patient here. She says, I would want to know definitely, because sickle cell is not something you want to see someone go through. You do not want to see your child go through. Whereas we have a patient who is opposed to the genetic technology, and she's like, what's the point? I mean, what are we trying to achieve? It's going to affect the parents more than anybody. So I'm curious to know, what is there to gain by the medical world having this information when it's not affecting them directly? It's affecting the parents directly. And so the social implication here, particularly as it relates to ethics, is that just because empirical studies include race or race variables, it does not necessarily mean that these studies are examining how patients within the same racial group or the same racial demographic have varied lived experiences and varied perceptions of genetic technology. A little bit more about what this means in terms of the results with sickle cell and the intersection of prenatal care. So I asked both my groups here, my sickle cell disease group and my non-SCD group, as Black women, do you think there are unique issues you face regarding prenatal care? And a large ratio of them said yes. One of my study participants mentioned that this has been problematic for a very long time. It takes more work to be a Black woman. And this is not about treating us different. This is about treating us the same. And then when it comes to my SCD group only, I asked, so how do you feel about reproductive care in the US? A large group of them said they're concerned or frustrated, disappointed, sad, burdened. And respondent here says, sickle cell pain is even worse than labor pain. I have a strike against me as a Black person, another strike as a woman, and then sickle cell, the burden and mistreatment during labor and delivery. So just to just give you a little bit more texture here of what it means to be a Black woman with constrained choices. And so in the manuscript that I'm currently writing, I talk a little bit more about the framing of these patient stories and illness experiences, but also the constraint that it puts on their everyday lives in the social context that they're in already. And you see here on the theme 1, the SCD lived experience must be taken into account. We have a respondent that says, being a Black person with sickle cell, going to a hospital, you're already labeled as a drug seeker. And they look at you a certain way, and you can hear it in their voice and in their tone. And for time purposes, I like to skip to theme 4 or T4, where the respondent talks about high-risk OBGYNs without sickle cell disease experience. And she says, I'm more of an advocate for midwifery. I wasn't able to do that because I was considered high risk. If there's going to be a situation where a woman who is termed high risk, but she's still going to a traditional OBGYN who doesn't have any experience with sickle cell, how is that helping? I think that to streamline things, have OBGYNs that specialize in sickle cell high-risk pregnancy. And so here she offers a recommendation for the field using her own lived experience, where she's often going to see a hematologist and then also having to go see her OBGYN and having to do the work and the burden work of educating both providers on her lived experience just to receive treatment. And so this poses a challenge for the field, deep-seated challenge, but I like to convert lemons into lemonade, or challenges into opportunities. And the challenge that is converted for an opportunity for the field is about framing. Framing is key here, framing the patient perceptions on non-invasive prenatal testing. And I laid out this conceptual model of what this kind of looks like. In terms of reproductive equity, that we need to expand reproductive equity to include genetic technology and not see it as a siloed or separate discipline, but to expand equity thereof by including patient perceptions of marginalized groups such as Black women with and without sickle cell disease, with and without genetic conditions or other conditions thereof. And this also is a cause for intersectionality. And without intersectionality, we run the risk of perpetuating structural racism altogether, because these are deeply intersected experiences for a lot of these persons in these predicaments, but also for how we do research in the disciplines, that we need to be more intersectional with how we approach solutions and recommendations for the field. And then I like to point to the last circle here, constraint choices, that when we fail to recognize that these choices, everyday choices, patients have to make under constraint contexts, that it can potentially increase patient mistrust. And so the social implication here, back to non-invasive prenatal testing, for example, is that just because a test is labeled as non-invasive, ethically, it can still be an invasive process if your options and your choices are constrained, potentially increasing ongoing mistrust in genetic technology and genetic advancements overall. I did write about this a little bit more in a paper that myself and my lab published, Human Genetics and Genomic Advances. And forgive me if the article screenshot is a little bit small there, but I like to point out 3 bullet points, is that from the article, that racism, not race, influences social determinants of health. And that social justice is about applying anti-racism approaches. But the key point here is to do it willingly. And to carry this forward, I also published another commentary that also talks about trust and patient trust. There was so much going on in the pandemic about mistrust. But one of the caveats that I pointed out with trust and censoring has a lot to do with blame. That we live in a patient blame culture or patient blaming dynamic. So to even get to the root of trust, we have to also backpedal and talk about who are we blaming? How are we blaming and framing Black women as problems or contributions to the problem of society? So shifting away from patient blaming for individual health behaviors under constrained contexts and shifting toward framing structural inequities. And so why is all of this important? What's the relevance, right? In terms of scientific innovation, we must include an expansion for reproductive justice, as my colleague, Dr. Flavin, just laid out the tenets of reproductive justice. But this framing also must include patient perceptions as told by marginalized groups themselves. And in my case, I study and focus here solely on Black women in the United States. And so the results that I proposed are told by the women themselves, and these women do and are living with genetic conditions that are often missing from clinical trials, but also missing altogether. And forgive me if you hear my dog barking in the background. But I pose 4 considerations. How do Black women perceive reproductive genetic technology? Why Black women resist certain genetic technology? How Black women experience race, gender, illness experiences, their relationships with their providers, and clinical decision-making. And what do Black women recommend as optimal in the forefront of reproductive health care reform? This is a critical time that we're living in terms of the world in these intersections, but also in terms of persons living with different types of healthcare morbidities and genetic conditions. So we must seek to expand sexual and reproductive health equity, specifically as in the field of sickle cell. As by 2050, the number of people with sickle cell disease is expected to increase by 30% worldwide. And as right now, I'm currently on the continent of Africa and West Africa and Ghana, where about close to like 1 in 3 Ghanaians experience sickle cell disorders and may or may not even know that they have sickle cell anemia. So raising awareness for screening, but also access to treatment. Here's a little bit more about my research on the ground at the Ghana Institute for Clinical Genetics, as well as where I work at the University of Ghana, Legon. They just launched the Ghanaian genomes. There's a picture of me at the front, the launch ceremony. And then we had a breast cancer awareness screening as well in October. So my closing words, ethics on everything. I am a scholar of my generation, so I try to use hashtags because it just gets the people going. But I would like to leave a quote from Bell Hooks that really resonates with me. The moment we choose to love, we begin to move toward freedom, to act in ways that liberate. And so I heard my colleagues say the word love, and I just want to echo the sentiment of the ethics on everything really means moving toward that freedom, toward that humanity, and also humanizing the research process for our study participants. So I'd like to close by saying thank you, genuinely, also to my amazing study participants and patients who I owe all of the honor of my research to, my wonderful colleagues at University of Miami, as well as the Bonham Lab and the National Institutes of Health, as well as in Ghana, and stakeholders in reproductive health and sickle cell communities worldwide. If you'd like to know more about my research or to connect with me, please email me at shamekathomas@hsph.harvard.edu or tweet me at Dr.T_the_scholar. So thank you.
I want to just remind everybody, please do submit any questions that you have via the private chat. And I will go ahead and ask them on behalf of the audience. I guess I just want to start by asking both of you if there was anything that particularly jumped out about the other presentation that really is reflected in some of your own thinking about these particular topics? It's a very, very big open question.
So much. Hold on, I need so much. I especially appreciated what you were saying about what I'm hearing is like the limits of choice. Like we often hear about, you know, pro-choice, anti-choice, but when your choices are so constrained as to be almost non-existent, or they're so dependent on somebody else respecting that choice, I found that quite just striking, not surprising. And similarly to your point about blame, and especially I do feel like when we blame, not only is blame problematic in and of itself, but we often, when we blame, when we misstate what the source of the issue is, or we ignore something that is the source of the problem, then that's also a kind of violence that's done that I think we often overlook when we're too busy blaming people and holding them accountable for things that are not 100% in their power. That just always strikes me. It kind of keeps us, it prevents us, I think, from actually doing things that do promote the health and well-being. So I was just really struck by that and hearing it in a different way.
Yes, thank you for those highlights. And likewise, for me, what stood out were when you talk about, where you were mentioning that providers can also, if they're not careful, can serve as police agents. I mean, that right there, I mean, is and it's a war cry. Is also deeply heartbreaking when you're already living in so many different marginal intersections and having to not access or have to hide your pain or hide your illness experiences for fear. Fear itself. I mean, that's like dehumanization times 10. I mean, and another point that you mentioned about reproductive justice and expansion, I just really echo with me altogether in the intersection of criminology and crim work there in prenatal care. It made me think of this quote that someone posted on Instagram. And again, I draw a lot from social media. That's a scholar of my time, and so we're online, right? But she posted, "What police do to Black men, doctors do to Black women." And that quote kept ringing in my ear as you were talking, Dr. Flavin. And so I was just really thinking about patients who have sickle cell disease, who are incarcerated, who are giving birth, who have to, you know, receive results from a genetic technology or lack thereof. And so how might my work intersect with crim work and their going forward? So I just really thank you for bringing that to the forefront here in the conversation today.
Yeah, so I was really curious to hear more from both of you about trust in the healthcare system, mistrust, distrust, and especially, so you've both highlighted different ways that you know, mistrust can be generated, either because of interactions with a system that will funnel you to the police if you make a misstep, or that doesn't actually take your interest and perspective into account. And so I was just wanting to hear a little bit more about how you think about distrust, the various ways that distrust is generated, and then what are the implications for that?
Yes, I can kickstart there. So when I think of trust, I have to think about the prerequisite. For me, what that means is blame, understanding what does it mean to blame or constantly be blamed for something, while also not being in the room these rooms where the power to make decisions about your healthcare and health policy is not necessarily, you're not given an option to either be there. And so when I think about trust, thinking of a colleague who wrote a piece in the Hastings Center report, is the title was, "Is Trust Enough?" And the title alone is captivating in itself, because she's arguing there, is trust enough? Is it enough to just trust? Because even after you trust in a so-called provider or in the system, now what? What's next? These historical memories still live. They still are permeated and embedded in the social fabric and the social frameworks thereof, and they still impact current day processes implicitly and explicitly. And so for me, responding to my colleague about is trust enough, I talked about blame and how we need to shift from blame culture. There's a book that, I love Dr. W.E.B. Du Bois is one of my favorite scholars. But in his book, The Souls of Black Folks, he posed a question, how does it feel to be a problem? And as I was matriculating through my time as a grad, that question sat with me, studying reproductive health and reproductive justice. How does it feel to be a problem? How does it feel to be a problem? When we talk about blame, how does it feel to give birth to the problem? Was the question that I tried to remix from Du Bois's question in my piece, my commentary. And so Black women are not just seen as the problem, but they are seen and framed or misframed as giving birth to problems. And when one gives birth to problems in a context where their choices are constrained, then how can we even get to the point of trust if we haven't disentangled and deconstructed blame and problems and who gives birth to the problems? So I'm gonna leave it there and allow my colleague to jump in. But that's my take to your question.
I'm gonna jump in with an amen. With an aim with, I need to mute this. Yes, to everything you said. I'm going to try to only add to it rather than repeat it. The first thing, though, when the question was posed was, I think that partly because the construction of medicine and savior complexes and power, but I do think it's deeply problematic to expect people to trust people in positions of authority without also asking, are you worthy of that trust? Meaning, is the provider worthy of the trust? Is the social worker, is the system? And I am, it's a rational response to chronic mistreatment and a lack of evidence that there's a reason to trust. So that is one thing I would want to say. I also, with regard to blame, I think, and I don't want to throw the word abolition out too casually, because I'm still trying to come to grips with what it means. But when you talked about blame, I think blame and punishment have just seeped into so many places. I worry about our failure, that we're going to lose the imagination, lose our ability to imagine ways of responding to things we should be concerned about without relying on blame and the threat of punishment if you don't comply. I think that we really need to do active, ongoing, constant 24/7 work to purge the ways in which we respond to a concern or we attempt to address something by resorting to punishment or the threat of punishment and blame. Because as I said, I think that even the whole mandated reporting for a positive drug tox, there's a nurse, Joelle Puccio, who when people, I was asking her actually, is there any condition under which you would support the testing of a mother, a birthing or labor mother? And she says, I don't need to. If I've earned and deserved their trust, they will volunteer far more information than could ever be gleaned from a single drug test. And so it really, so many of these policies we have, I think we need to ask ourselves, why do we have that and what's underpinning it? And are there other ways that are more, I don't know, I can start to get a little off, but I just really think we need to revisit or take a good hard look at the ways in which blame and punishment are undergirding far too many of our so-called helping professions and our social supports. I think that's what I'll end with.
Yeah, I think that's really interesting. And I think it's partly there's like problems on two different levels. So one is there's the automatic connection to blame. And then there's second, like the implication of blaming with our systems of punishment as well, or systems of exclusion. So not only do we think that someone might deserve to be put into the criminal justice system, but there might be withholding of other sorts of supports as well, because there's this assumption that the person deserves any sort of difficulty that they're facing. So I've got a question from the audience now, moving things in a slightly different direction. So this is about sort of the history and the way that we're currently thinking that the present is affected by the past. And so this is for Dr. Thomas. Has the Henrietta Lacks experience affected Black women's fears of genetic testing? Perhaps do they think that their genes could be used for other purposes, or did those sorts of discussions come up at all in your interviews?
First of all, I love that question. So whoever asked, thank you so much. I hold space with you. Absolutely. When I am interviewing patients and talking to them about their healthcare experiences, I might just be, let's say, talking broadly about non-invasive prenatal testing. And we know non-invasive means that it's just blood sample goes to the laboratory to be screened, get your test results, and then you make some decisions after that for either more invasive testing, such as an amniocentesis, which can increase prenatal or pregnancy loss, or you just keep those predictive results and go forward as is with. But yes, even to get to the patients to talk about their perceptions of the genetic technology, they often talk about their memories. I often call them horror stories. Even if these stories do not happen to them directly, they probably happen to an auntie, sister, cousin, grandmother, friend, somewhere that they heard. And Henrietta Lacks has come up, particularly when it comes to sickle cell disease, sickle cell treatment, as well as feeling as though people are not telling you the truth and their informed consent about what they're doing with your blood sample thereof. And so for when I'm interviewing Black women and using an approach on narrative medicine, I try to be very intentional and very sensitive to the historical ramifications that I can't just ask about or just expect an answer on just this one technology, because this one technology is deeply rooted in historical memories that may or may not have happened to my patient or may not have happened to my study participant, but they still come up. And they have implications for how they might perceive the genetic technology, what they do with those clinical decisions. Do they decide to go to their prenatal care appointments? Why do they resist going? How do they find new providers? What do they do when they can't afford second opinions? When they can't afford to even get NIPT test results for something like Down syndrome or trisomy 21, 13, and 18, or now going forward with sickle cell disease. So this is why when I give presentations and I write papers, I always try to honor not just the fact that I study Black women as a single population, but also to honor the contributions that Black women have made to science. And one of those persons in genetics is Henrietta Lacks. And we have groups of white scholars who have won prizes Nobel Prizes or awards for the HeLa cells and innovations, while her family still lives in, at poverty level or slightly above it. And so it's very unfair, deeply heartbreaking. And so patients bring these stories up. It comes to the data, and it's there. And so I think that question is something that, one, is hard to answer completely, but the awareness that we even have to ask this type of question, it shows you that it's still present. The history is still present today.
And to follow up with the last bit of what you were saying, so in your discussion, you mentioned that justice should include access to genetic testing and other sorts of resources. Mm-hmm. Do you see that as partly based in the history there? So sort of like giving due to the people who contributed in a way that their contributions were not previously considered? Or do you see it more as like a modern day equity thing, or is it some combination of these issues?
That's a really great question, Dr. Swartz. I think every scholar has their own approach to this. But for me, as a Black woman who has been throughout the scientific pipeline process, I need to honor and hold space, not just for the patients who are missing from clinical trials, missing from the data, but also the women who have largely been hidden figures, who have been hidden, and scholars who have been denied the right to even have credit. So when we talk about ethics, it's not just a one-sided approach. Ethics is something that is a double-edged sword. It is something that is twofold. It's overlapping, it's intersectional, and it's something that cannot just be for study participants, but it has to also be for the workforce, and the contributions of scientists and scholars, laypersons who have been much more salient and prolific in these contributions, but they just may not have had institutionalized PhDs to claim their lay knowledges. So.
Great, thank you so much.
I hope I answered your question.
No, absolutely. I think that there's me posing the question as is it this or that? I appreciate thinking it's all of the above. It's some combination of these things. So I now have a question from the audience for Dr. Flavin. So I wonder if you could talk about how you came to see the criminalization of pregnant women, especially BIPOC women, as damaging and as something that urgently needs to be countered. How do you think racially privileged providers can also be brought around to anti-racist principles? And I think that last part is certainly open to both of you.
I'll try to be concise. And I would just say that it's definitely still an ongoing work in progress. I think, I started out studying the criminal legal system and the arrests and prosecutions of Black men and women who were convicted of drug offenses in DC. I really did not start out I'm not proud of this. It's just a fact. I wasn't a particularly critical thinker. I think I had decent racial politics, but I was slow to grasp the magnitude and how harmful this was. It was in the dissertation research where I realized, wait a minute, people are being punished not only for their crime, but also for how they're reproducing, for whether or not they're a good parent, whether or not their child lives with them. I was finding these patterns that just made that undeniable. Again, whether it was intentional on the parts of police, prosecutors, and judges, the pattern that I was seeing meant that if you controlled for what the person did in their criminal record, the two biggest contributors to how severely the system would respond, you still found that if you had a child, for women, the group that was punished the most severely was women who had children and did not live with them. So that's when we're like, wow, we are punishing people for their reproduction. That was kind of the beginning. Now, at the time, I still adhered to a lot of really mistaken notions about, for that matter, the history of the criminal legal system, or for that matter, what a humane response to any social problem, but including problem drug use, mental health, that sort of thing. So that was kind of the start. It was, it's been kind of a varied journey, but I do feel like, for example, for me, the precursor to a lot of transformative justice and abolition work was harm reduction, and recognizing that we can be concerned about a harm that somebody might be inflicting on themselves or the people they care about, but there are responses that do not depend on punishment or the threat of punishment. So actually, I forgot what the latter part of what you said was, and I'm not even sure I adequately addressed the first part. So could you?
So the second part was, how do you think racially privileged providers can also be brought around to anti-racist principles?
I'm counting on it. I mean, I think that is the other thing, and I appreciate too the mentions of equity. That the other thing that has really, I think, is important for people to realize, it's not, the onus is not on the individual pregnant person to overcome the barriers or to overcome the racism. The onus is on the people who are putting them in place. And I would say not only on individual white providers, but our institutions working in concert, challenging. And in fact, I don't want to be too strong on here's what it must look like. I think there's a lot, we can move on a lot of fronts in a lot of different ways, but I will not in any way, I wouldn't want to absolve any group, and particularly not people in positions of power and authority and privilege, including white providers. It's not enough to be disturbed by it. I think it prompts us to say, what can I do both in my everyday practice and in the other spaces that I occupy to address it? So, and I do think, I don't want to just seem like I'm wired for optimism, because I'm not, but it's not like we've tried everything to address these problems and nothing has worked. We really haven't. We haven't even started. So I am heartened by a lot of the conversations I'm hearing in a variety of sectors around other ways of approaching it and taking a more equity-based approach, and subjecting some of these normalized practices like informed consent. If that person does not, I mean, that would, specific and meaningful informed consent just seems so fundamental, and we don't have it. Signing a stack of papers on your way into birth and not realizing what's in there, what the implications, is not what healthcare. So I'm, if not optimistic, I do feel like this is a moment where people are focused and concerned and questioning and willing to move on the concerns that they have. So yeah, that's where I'll stop.
Hello, I'm back there. My apologies. The internet glitched.
That's quite all right, and perfect timing, because I do have a question for you from the audience.
Okay.
And so thank you. These are compelling talks. I wonder if Dr. Thomas could speak further to the importance of applying anti-racism principles willingly. So what are some of the ways you would call to see this done in the context of medical institutions and research?
Absolutely. Thank you for that question. I also hold space with you too. Thank you. So when my colleagues and I sat down to write the piece on anti-racism, we really were thinking critically about the word ethos, right? And so oftentimes diversity is seen as numbers or quotas reaching some type of numerical value, but persons are not necessarily numbers. They are humans, or should be considered as such. And so for me, I see diversity as an ethos. as a culture, as a climate, as something that needs to be fostered and thought of ongoingly, intentionally, with introspection and reflection. This really lends itself to what I mean by anti-racism. And so when we talk about anti-racism, just because you study race or racism does not necessarily mean you're using an anti-racism approach. And what I mean by that is kind of like a twofold approach here. When I say willingly, I mean intentionally. It means it's an action step. It's more of a call to action. It's also more about learning to sit with the discomfort. And so a lot of these topics are very uncomfortable for all of us, for some more than others, but they are very heavy topics. Oftentimes working with patients who've experienced multiple intersections, we're considered first responders of trauma, racial trauma. We're holding space. We're dealing with a lot of narratives that are very deep-seated in the historical fabric of racial discrimination and other isms thereof. But it means sitting with the discomfort, not being so quick to rush to solutions without understanding and recognizing that we have a problem. And when I say a problem, we have multiple problems that are often overlapping. And so a willingness to be aware, a willingness to take an action step in your research, not just in your research, but how you do your research. How you do and practice your research empirically and thoughtfully with the tools that you use. Who's on your research team? Are we checking in with our RAs? Are we checking in with our PIs and co-PIs, our postdocs? How are we making sure that everybody is being has a fair chance, or at least heard and seen? And on our research projects, how are we practicing methodological equity? For me, this gets at methodological justice. And so I also talk about centering, and that's the last part there to answer your question. Centering, and I just say a marginalized group of, for example, I study Black women. Centering Black women's narratives is an example, right? And it could be anyone's narratives that you try to, let's say, center who have been decentered. But centering Black women's narratives for me means first that we have to see Black women. And to be seen is also to be prioritized, and not just prioritized on paper and in theory, but prioritized in funding allocation. And this could be in terms of a genetic condition such as sickle cell, funding allocation for studying projects such as on sickle cell disease and or Black experiences in healthcare, or Latinx or Afro-Latinx, et cetera. So those are just some brief examples. And also, if you were to reach out to me, I could pass forward some of my commentaries and on anti-racism approaches and the different tenets. We created a model that has been used throughout classrooms, and some questions to help different groups brainstorm on how to go forward with applying anti-racism approaches in their research. So that's just a starting point. It's not exhaustive, but I hope that answers your question.
Yeah, and it just like made so many thoughts go off in my head. And so I want to follow up with one of them, pretty briefly, given like your discussion about equity in the methodology and checking in with, the people who are engaged with the research, people who are doing the research. And given the fact that, as you said, sometimes you're sort of like on the front lines of seeing this trauma and witnessing this trauma, we had a talk a couple of years ago that was thinking about the way that interviewers might be experiencing vicarious trauma because of the kind of research that they were doing. And so I'm curious, like, have you done any work with your research assistants or anything like that regarding that sort of experience?
Yes, absolutely. So we actually, I held a workshop for in qualitative research as well as mixed methods, where I invited RAs and then one of my mentees who's working on her PhD in clinical psychology and counseling. And she gave us a thorough talk about vicarious trauma, ways to integrate your mental health or self-care practices into your research. And so for a lot of us who are studying race, studying racism, studying different isms and the history and the memory and genetics and epigenetics for some people. So it's just, how do you show up to your work and still be well is a question, because we can't just take this off when we go home. We're taking these topics with us. They're moving through our minds, moving through our bodies. They show up in our own clinical encounters. We're studying medicine and also having to negotiate clinical encounters in medicine simultaneously. We're the object and the subject. So how do you still do this research and still be well, still be healthy, still be seen in contexts that are violent spaces subjectively, so to speak. So we did hold a workshop. We allow our RAs, our postbacks to speak, because oftentimes they're, just given tasks. But I try to humanize my own research projects by allowing my RAs to have voice and narrative, life experiences, thoughts, expressions, because I know what it feels like to be, a Black woman who has to, have had, experiences where I was silenced. And so voice is just one tool, and narrative is just one tool. But yeah, I hope that answers your question. But just these workshops are not a one-time thing. What I mean by this is an ongoing process. It's an ongoing, there's no one-time step, but practicing intentional anti-racism approaches is ongoing, quarterly, check-ins with the lab. How are you? How's your lived experience going on at home? How do we have conversations about race? Do we all have shared definitions of racism? Do we have shared definitions of intersectionality? Let's talk about it. Let's not be afraid to be uncomfortable, so we can make progress.
And Jeanne, I would invite you to say anything if you have anything to add to that as well.
No, I don't have a particular desire to have the last word, but I will just add to that I've also found it. I want to note that the work that I do, particularly around problem drug use, couldn't be academic if I wanted to, and I've kind of made peace with that it's okay. It doesn't have to be, and it also doesn't have to be relentlessly depressing, because the other thing is, I'm often, we're all more than who we appear to be at a given moment in time. So one of the things that has helped sustain and fuel me is I count as friends. I've benefited greatly from the relationships I've had the privilege to develop over the years, when you gain the trust of people who've been so horribly mistreated by the system, and also to see them overcome and to see them contribute. So I've also found finding my home or my people, which has been tough during COVID when things get canceled, but like harm reduction conferences have often been a really neat place for me to land, to see the advocacy, the organizing that's happening among people directly impacted. So I would just kind of add that self-care can look like a lot of things, including being with people who are experiencing it and are keeping on. And we have so much to learn, not just in terms of what shows up in an article, but just in terms of how we approach life and how we are with people.